Good morning, good afternoon, everyone. Welcome to today's DCB Academy session. It's both an honor and a pleasure to have Dr. Ugo with us from Italy. He is a renowned expert and key opinion leader in the field of coronary artery disease, particularly in coronary total occlusions. Today, he will be sharing his valuable insights in coronary physiology in this setting of CTO. We are so delighted to have him here and look forward to a highly informative session. Dr. Ugo, thank you so much for joining us here today. The floor is yours. Thank you.
Thank you, Sarah, and thank you for all attendees and participants and moderator for this fantastic session. Thank you, Bernardo, as a friend, but he gave me this opportunity to take a part of DCB Academy, an academy around the world that involves a lot of physicians, a lot of friends, and we don't speak only about the DCB. For example, today we speak about CTO, but it's important to have a more interactive session because I would like to involve you in a discussion. Thank you for this opportunity because speaking about the coronary physiology in general is not so easy, but in CTO we have a lot of variables that involve a lot of different variables. It is very tricky to speak about the coronary physiology in the setting of CTO. First of all, so we have a question: what coronary physiology tell us before and after the treatment of chronic total occlusion? This is an example of a chronic total occlusion. We have a recent 3 months before occlusion of RCA, you can see here, with the donor vessel provided by LAD, is a diseased LAD, and also we have a critical butt focal stenosis of a diagonal branch. First of all, I would like to introduce the collateral collateral classification, because when we speak about the physiology, we need to involve a collateral system that sustain the CTO distal vessel. So we have 2 anatomic classification and 1 functional. For the anatomic classification, we can use the Renthrop classification, 0, the degree are 4, 0, 1, 2, or 3. The Renthrop 0 classification when we have no filling of collaterals. The Renthrop 1 is a filling of side branch of recipient artery via collateral channel, but without visualization of the epicardial segment occluded. The Renthrop 2, we have a partial filling of the epicardial segment via collateral channel with a visualization of CTO in the distal part, and the Renthrop 3 is a complete filling of the epicardial segment and complete filling also of occluded coronary artery. The Werner classification is another classification of collateral branches. We have three degrees of classification, 0, 1, 2. The Werner grade 0 is the figure A, no continuous connection between donor and recipient artery. The Werner classification grade 1 is a continuous connection, but the side of the collateral connection have a diameter inferior of 0.3 millimeter. The Werner grade 2 is a complete and continuous connection by the channel, and the channel epicardial or septal, depends on different cases, it's a diameter measure or 0.4 millimeter with a complete connection of the occluded vessel. We have a speculative collateral flow index classifications, a functional classification. We have 2 different grades, CFI measured than 0.23 or CFI inferior to 0.23. Measure than 0.23 is a high collateralization like this case, and CFI inferior than 0.23 0.23 is a low collateralization. It's important, this classification, because it's associated with inducible ischemia. By the way, pay attention, because we don't use this kind of classification. This functional collateral flow index is not used because of speculative, because it's experimental. So we need to occlude the vessel, to check with the probe, the distal part of pressure Y, after the occlusion of the vessel, to check the pressure of occlusion and the ratio with central venous pressure. So is impossible to have this data, this index, in normal cases. So we use the first two anatomical classification. I introduced for today a case, a recent case of the last year. I studied this 50-year-old male with active smoker, different risk factor, without cardiological medical history until July 2024, when he had acute intense typical chest pain without hospitalization, because the patient don't come in our hospital, stay at home, but he come to our attention in October 2024 for typical angina CCS2. We think that in July 2024 he experiments the acute coronary syndrome with acute myocardial infarction. In fact, if we check the ECG, we know the presence of Q wave, necrosis of inferior wall, you can see here. Okay, and the echo confirm the presence of possible inferior myocardial infarction, recent, 3 months before, of the inferior basal wall, you can see, but the normal general contraction of left ejection fraction, left ventricle, without any problem, mechanical problem, or valve problems. So the coronary angiography showed the presence of total occlusion of the right coronary artery, and we have a lot of septal branches connected as a collateral provided by LAD. But you can see the presence of diffuse in the middle part of LAD, diffuse disease is involved, the LAD, and the focal critical angiographic critical stenosis of side branch is a diagonal branch of this system. Is a great RCA. You can appreciate here not only the septal channel and the PDA, but also the PL of originating by the right coronary artery. This is the situation, okay? So we have CTO, because it's measured at 3 months occlusion of the right RCA, the right coronary artery. And then we have a donor vessel provided by LAD, is a diseased LAD. So my question for you is, how will you treat this case, this situation? So this is the first crossroad. The medical therapy, you think there is a CABG patient, or the CABG solution is better for this patient, or you think that PCI, you can solve the situation with the PCI. What do you think about this first crossroad? Just to have an interactive session, what do you think?
It's a good case. I think it's something we see quite frequently also. So, where you have a complete occlusion of one vessel and then the donor vessel with collaterals, which has moderate disease. And how do you decide whether that moderate disease is functional significance? I think that's always a challenge. These days with imaging, we can measure plaque burden, we can measure luminal area. So sometimes that's useful to decide whether the moderate lesion is significant or not. But I think you mentioned a little bit about functional assessment of the donor vessel. I think FFR is probably not reliable unless it's very, very positive. That's my understanding. Is that correct? But maybe the maybe the the sort of adenosine free ratios. So your IFR, your RFR, they're more reliable in this setting because they give you the spot functional value. Is that correct?
But do you think there is a difference between IFR and RFR, or between FFR and IFR?
Yeah. I think FFR, when you've got a donor vessel, because the myocardium that's supplied by that artery, the distal myocardium is two territories. Maybe more territories if there's collaterals to other vessels, but it may not be as accurate. So I think if the FFR is very strongly positive, say 0.6 or 0.5, then I think even if you fix the CTO, it's highly likely that if you repeat the FFR in the donor vessel, it will still be positive.
But you know, the ejection fraction is over 50, yeah?
Yeah, I think you mentioned that.
Did you consider SPECT?
We don't consider SPECT in this case because the patient come to our attention for chest pain, for typical chest pain. So we are in this setting. We can also stop the procedure angiographic. We check the angiography, then we stop, and we also can use the SPECT, for example, or magnetic resonance stress magnetism resonance to test. Yes, it's a possible, but we have also the instrument inside of our lab to decide. I think.
In the LED, it will be definitely going for the false negative results because of lot of collateralization towards the RCA. Nowadays, the CTO operator mostly they are doing the total ischemic burden in the territory of CTO vessel before going for this high risk intervention. So I will go for the I will go for the total ischemic burden by getting the viability and ischemic burden towards the RCA, and I will open the RCA first, and later on I will go for FFR in the LED to look for the real results in the LED.
Yeah, there are a lot of possibilities, I think. But now you see the screen of my presentation, or you see me and the
environment? Yeah, we are getting your voice and
you see the screen. Yeah.
Not my presentation.
Same, yes. Both together.
Yes, for your presentation, Dr. Ugo.
Just a moment. I would like to have the control of my presentation because I leave. Okay, yeah, okay. So the question, Bernardo, is this. We are here, okay? We have a total occlusion of the right coronary artery. It's a recent 3 months by the CTO, real CTO, with a lot of collateral branches provided by septal. The donor vessel is LAD, is a diseased LAD because we have an intermediate lesion, angiographical intermediate lesion of the mid LAD. So the question is, what do you think to treat better this patient? Medical therapy, okay, we are all agree that is the last solution for a very old patient that he don't have any possibility, therapeutic possibility. So we discuss about CABG or PCI. So we have, what do you think, Bernardo? This is the situation. Is a stable patient that he can.
How old is this guy?
For a typical F4 chest pain CCS2, but 50 years old male patient. Okay.
Oh, young one. Yeah. So I would do. I don't know if I'm anticipating anything before deciding between PCI and the PCI. I would do a physiological assessment of this LAD to be sure it's a significant, because angiographically, I'm not sure it's significant. So having DABs, I would do a physiological assessment there and then plan a CTO a recanalization.
Yeah. This is my opinion, because we need this is the speech of today. You involved me in this discussion about the tricky topic provided by the coronary physiology and the strategy. We would like to move about the PCI, if we are in our mind this possibility first. So we can use the physiology, but also we can use the imaging of the donor vessel. We speak about the donor vessel, or angioguide PCI. So when we speak about the physiology, the concept of physiology, the physiology assessment, today we use the new concept is a full physiology. So it's hierarchical use and testing different part of the coronary tree. I mean, first of all, we can check the epicardial assessment disease. So we have the possibility to use 4 parameters: PD-PDA ratio, RFR, contrast FFR, or normal FFR, and also the pullback, because it's important to use the pullback. I believe in the pullback because the pullback can provide the correct point when we have the jump and the major critical or not stenosis of our curve in terms of jump or drop of FFR. By the way, we can test also today the macrovascular system. We have the possibility to use 2 parameters. There are the CFR and a new one, the IMR, to test or not if you have the dysfunction of the microvascular disease. By the way, we have also the last possibility to test also the vasomotor, the vasomotricity of the coronary tree in terms not only epicardial, but also the microvascular spasm. A new concept, this one, because we have an epicardial spasm when we have clearly the spasm in the epicardial tree with a clinical with the elevation and the evidence of epicardial spasm. But we can have also the only microvascular spasm, and then we can have a combination of microvascular and epicardial spasm with change in terms of IMR. So the IMR is a new concept that help us to distinguish between microvascular or epicardial spasm. So I start with my live cases. This case, okay, you can see the disease of LAD. I put my guide wire in the zero coroventis guide wire in the distal part. I check the RFR. I check the basic FFR, and then I check and test the full physiology. So I start with infusion, venous infusion of adenosine. You can appreciate the increase of heart rate beat and the decrease of medium of pressure. So the infusion is good of adenosine. And we use 3 flash with the coroventis to check all parameters. So we reach this. We found of my donor vessel different parameter. For example, we had the FFR 0.79. We discussed before the introduction, Bernardo, about the value of the FFR of the donor vessel. This is the main topic of my speech of today. We have also other parameters like RFR. It's correspond to volcano. IFR is not hyperemic parameter, okay. PDPA, we have a CFR of this LAD 2.4. It's not quite normal, but not so high. And IMR, so we have 30 of IMR value is dysfunctional microcirculation. So, but the question is, what is the applicability and interpretation of coronary physiology in the setting of chronic total occlusion? When we speak about this topic, we introduce 5 parameters. So we have the concept of coronary, the collateral still, the collateral regression in the setting of CTO clearly. We introduced the concept of pure physiology data provided by IFR, FFR, but we need to distinguish if we want to check IFR, FFR, or the CTO vessel or the donor vessel, two completely different, okay? And the microvascular dysfunction. For the mechanism of collateral still, we have this mechanism. In general, at the rest, during the rest condition, the perfusion of the myocardium sustained to the chronic total occlusion is supplied by the donor vessel, okay? Through collateral. The microcirculation is in a chronic state of vasodilatation to increase the perfusion pressure in the distal part of the CTO vessel, okay? As a result, for example, if we consider 100 ml minute flow reach the donor vessel myocardium and 50 ml for minutes in the collateral dependent myocardium. During the epiremia, the donor vessel microcirculation is able to vasodilate greater than the maximally exhausted collateral dependent myocardium, resulting in preferentially more flow to the donor vessel myocardium with a reduction in the collateral dependent myocardium. This is the concept of the still. But we have different evolution of collateral. So the concept of collateral circulation is a dynamic process. He is a typical life cycle because we have the collateral recruitment, we have the new angiogenesis, we have the collateral remodeling in terms of diameter. We can found the presence of increase or decrease in terms of diameter of collaterals branches. We have the neocollateral formation, the angiogenesis, but we can have also the collateral rarefaction, for example, after a success PCI CTO. In general, this is the situation. So we have in the upper part the stenotic donor vessel, in the part below the CTO vessel. So when we have a donor vessel supplying the CTO vessel distal to the occlusion via collateral, okay. As a result, the territory of myocardium supplied by the donor vessel is larger, okay? And the overall flow in the donor vessel and across the proximal stenosis is greater. When we reopen the CTO, the flow also in the donor vessel change, is the flow. The absolute flow is reduced. We have a normal flow in the CTO reopened artery, so we have a regression of septal branches and collateral, so we have the solution also of the still. When we speak about the the physiological data, for example, I found the presence in my case of 0.79 of FFR, RFR 0.85 with IMR dysfunction, but we need to consider this. This is all studies that are done in the last 2 decades about the human physiology in CTO setting. When we speak about the physiology data of the CTO vessel, this is the physiology of the CTO vessel, okay? So we have Werner performed a fantastic and elegant trial 20 years ago. It's crazy, with the consideration of the Doppler CFR and the FFR. But when we arrived to more recent trial that involve only the FFR that we use normally in our cath lab today, we found the presence of increase, dramatic increase of the FFR in the occluded vessel, but is normal that we have a double of increase of occluded vessel after reopening the CTO. So we start with 0.45 of medium FFR in the occluded vessel, okay, performed and checked through the occlusion. When we reopen this vessel, clearly the FFR increased to from the 0.45 to 0.90 and normalize at 4 months. When we consider the donor vessel change, it's a tricky topic because it's not so easy to understand. In fact, we have, for the donor vessel, we discussed before that the donor vessel, we can have a tricky FFR also, because what is the significance of 0.75 of the donor vessel? Is a disease of the donor vessel, or is low because the donor vessel supply to a larger myocardium, or not only of the donor vessel, but also for the occluded vessel? By the way, when we reopen the CTO, we have an increase of FFR of donor vessel from 0.7678 to 0.82, and increase in 4 months, but depends of the quality of the donor vessel. Also, for example, if we have a normal LAD, in my case or not, in my case we have a disease LAD, what is the significance of the LAD diseased? In terms of collateral fractional flow reserve, clearly we have a decrease of collateral flow because we have a regression over time of the collateral vessel. So we pass from the 0.40 to 0, okay, or 0.18 in 4 months, because we have a passivization, a regression of collateral vessel. In graphic, we can represent this in graphic situation. So we have normal coronary artery, we don't have CTO, we don't have any disease. So the myocardial FFR is 1 PD PA, okay? When we have an intermediate stenosis without CTO, okay, for example, here we are the presence of intermediate stenosis of RCA and normal LAD. So we have the PD PAs depend of the drop of pressure through the lesion, clearly. Okay, this is the normal. Normally we check it with FFR in this situation. Completely different when we consider the CTO situation, because the FFR is 0 before reopening the RCA, but we have a myocardial FFR of the occluded vessel because we have a collateral still, because we have a collateral flow provided by the normal LAD, by the donor vessel. So we have a less, but we have a pressure of perfusion. What here we have the situation of when we check the physiology before, after the CTO reopening PCI, and at the follow-up. For example, we study in terms of resistance, in terms with using the Wood units, and we use the flow. The FFR is 0 in occluded vessel. Okay, we have an FFR of collateral, 0.33. We have an FFR of donor vessel, 0.78, with a total absolute myocardial blood flow, 250. We have a resistance in the donor vessel, 230 Woods units, and typically the resistance is 0 of the occluded vessel. We have opening of the resistance. We don't have a myocardial impairment in the CTO setting. After the PCI, when we put a stent, we had the changes of physiology immediately and at the follow-up. Immediately, because we have a normal restoration, the flow of the occluded vessel. But when arrive the flow directly to the myocardium of the occluded vessel, we have a rarefaction, a passivization initial of the collateral, and an increase, dramatically increase of myocardial index of micro circulation in terms of increase of resistance. And it's curious that that follow-up, that myocardial dysfunction solved with the normalization of the resistance of the previous occluded vessel, with normal resistance also for the donor vessel, and the absolute myocardial blood flow in the donor vessel decrease. So the FFR of the donor increase and normalized if we don't have any stenosis in the donor vessel. Finally, I use this flowchart, this algorithm, because I like in physiology, so I appreciate this algorithm when we have an intermediate, like in my case, an intermediate stenosis in the donor vessel. We can have three situations. If FFR is more positive, more with a value of inferior 0.7 or IFR inferior 0.80, revascularize both CTO and the donor vessel, because it's more positive FFR, so we have also a positive, in general, we can consider positive also and critical the stenosis of the donor vessel. If we are, like in my case, in the gray zone, perform first CTO, and after 3 months or 4 months, check with the new physiological guided PCI of the donor vessel. If FFR is negative, measure 0.80, or IFR measure than 0.90, revascularize only the CTO, because the donor vessel, the stenosis of the donor vessel is not critical. So in my case, I in a gray zone situation, okay, but what do you think?
Why do you say gray zone? Why do you say gray zone? Can you come back to the values? Yeah.
Yes.
So FFR 0.79 is positive.
Yes, but the IFR or the FFR?
No, I mean FFR.
The FFR 0.79 is a gray zone, because with this algorithm, we consider more positive to provide a revascularization of both CTO and donor vessel when we have an FFR more positive. But if FFR negative, but not negative, but 0.80 or more, revascularize only the CTO. We are on the middle.
I mean, analyzing all of these parameters, don't you think that can lead to some confusion if the results are not only on the same side? I mean, if they are all positive or all negative, it's fine. But if some of them are here and some there, don't you think that this can create more confusion, analyzing all of them? Because usually not in the CTO setting, but when you use physiology, you do the resting parameter. If it's positive, you go with PCI or cabbage, whatever. And if it's negative, you go with FFR. But always analyzing all of this, don't you think that can lead to some confusion?
Yeah, also we have an IMR dysfunction that confuse of the confusion, I think. But is not, if we analyze, for example, only the FFR or RFR, the corresponding volcano non-hyperemic IFR, is not completely negative, is not completely positive.
Yeah, we are using a different cutoff from the usual ones, because, we're saying that this vessel is different from a normal vessel in which we do the physiology. It has a bigger...
Yeah, that I got. That I understood, yeah.
So, what they proved is that when they are in this, let's say, gray area, sometimes you rule as positive lesions that may not be positive if you evaluate them after doing the CTO.
But I'm curious, Bernardo, after the physiology evaluation of my case, what do you have done in my case?
So there are many considerations that we can make.
Many factors.
Of course, this lesion is in the middle AD. So I would try to understand, because I didn't see the moving images. First of all, an important information that I would like to know now is which is the eventual path for a retrograde approach. So is this path going through this disease part of the LAD or more distally, for example?
Look here. Just a moment.
Sorry, I was not there when you presented this information. Yeah.
Oh, don't worry. Okay, this is the CTO. Okay, the RCS. Okay, we don't have any antegrade visualization of the distal part of the CTO. By the way, we have a Rentrop tree, complete visualization of the distal and the whole vessel of RCA provided by septal channel. Look here and look here and look here.
Yeah.
Cranial.
Yeah, let it play. Okay, so this is a possible path which is distal to the lesion.
Yeah.
Because the first big septal doesn't seem to go there. Yeah. So then we have nothing. So all of the path seems distal to the lesion. What do you think?
So we have in the middle part, but the first septal, yes, it is possible that is anatomically connected with the PDA, but not functional.
Because the idea here, this is before deciding any treatment, is if you do PCI here, then you can impair the possibility to go retrograde.
Yeah.
Because, if you put a stent, but also if you use a DCB and you dissect it, you can have big issues. So I would, in this specific case, would treat the CTO trying antegrade. There seems also antegradely sort of white thing, which could be also a thrombus from the antegrade. So I would try to do it antegrade, and if not, trying retrograde before any potential treatment of the middle AD.
Okay.
Then once you have fixed the CTO, you can reassess it, you can redo physiology, you can do imaging if you want to stent or to treat it, or you can do, again, only physiology, or you can also follow up the patient and, as you said, reassess after 2 or 3 months. So you can do a lot of things. But first of all, I would take care of the CTO here, in this case.
Yes.
Hello, I had a question. So now that you've done your physiology, and say now you send the patient for bypass, for consideration of bypass heart team. Now, a lot of the times the surgeons, they look at the angio and they say, no, this is a moderate lesion. Do you think a lima will stay open if you put a lima on this vessel? I think PCI is a good option here because I don't think a lima will stay open.
But I think that this is a very timely and interesting question. I don't think that Fabrice ever considered this option, as I would have not considered this option. But in the real world, you have the middle AD lesion with the CTO of the right. Many physicians would go for cardiac surgery consultation. So that's an important point.
Yes, another
Fabrice,
yes.
Which is your opinion?
Another important point, and for me, in my mind, that we need to treat as PCI or as cabbage the vessel that require the revascularization. Because if, for example, if we follow, as your opinion, Bernardo, this algorithm, we perform first the CTO, we recheck the physiology after 3 months, and if we look and we check the presence of negative FFR, we don't need to bypass a patient for a not critical stenosis. This is an important point.
And so, it would be too late for CABG, with a mid-LAD lesion, you already revascularize the CTO, too late for CABG.
Yeah, yeah. So I mean, these cases get presented all the time. We see it at our heart team meeting, and really, like we've discussed today, it's not much point for them to have CABG because, in actual fact, once you revascularize, say you put a vein graft on the right, then the flow down the LAD is not compromised. Then the lemur will become atretic. So in actual fact, you might potentially cause more harm by doing bypass.
Yeah, so this is another reason why we didn't consider CABG in this patient.
Yeah.
Another thing, what about this value? This is 0.70 less than. Normally, when we are considering the FFR, the value which is less or less than 0.80 or 80, we are considering it is a significant FFR results, and we are opting for PCI. But in this case, as you see that this value is less than 0.70, it is significant and reversalize both. So what is this gray zone? I need to understand this gray zone. This is 0.71 to 0.79 or?
The gray zone is between, if we consider the FFR is between 0.70 and 0.80.
Okay, in between. Okay.
Between.
Okay, I understand.
The middle. So we need, but easy to understand because the very positive FFR is like to possible that we have the CTO situation and the critical stenosis of the donor vessel.
Okay.
And the negative FFR, it's possible, and it's easy to understand that it's possible that we don't have a critical stenosis of the donor vessel, but only the CTO. So we need to revascularize only the CTO when FFR is major than 0.80. But I finish my case with investigation and using the imaging, okay? So integrate the physiology data with the imaging because I would like to check this stenosis. And surprising, look here. I don't know if because it's very fast, the OCT, but we can appreciate after this slide. Look here. We look on the middle when we arrive on the part of critical stenosis. Surprising, we found the presence of the disrupted, very complex, desiccated plaque of the middle part of the LAD. So this justify also the presence of alteration of IMI.
Yeah, this is something not expected. I agree with you. Though I have to say that, as I would have done, if you have decided to do OCT here, you already have decided to treat this lesion because you know that it's going to be positive in terms of area reduction. Okay, so I couldn't expect this plaque, this ruptured plaque, but I could expect in that very point a focal critical stenosis by imaging.
Yeah, but you are not surprising.
No, I'm surprised by this finding for sure. I would not expect that.
Yeah.
So this is why probably the patient has these symptoms.
Yeah.
Because the only CTO in a young patient, only CTO with a good LAD, no flow impairment, would have probably would have not been that symptomatic. Only I would have expected the angina only for high degrees of effort. And from what I understand, this patient had a low threshold angina.
Yeah, because but the RCA is not so small RCA. It's a great RCA that with
yeah, it's not small, but you already have collateral flow. With the normal LAD, I would expect not that low threshold angina. But medicine is never predictable, so you can see everything. I have another comment to do on this case. Then you can show us how did you manage it. So I'm an imaging guy. So you are converting to physiology. You used to be an imaging guy as well, man.
Yeah.
But all of this information that you have with imaging, you don't have with physiology. With physiology, you have this weird 0.79, 82, MRN, all of this stuff. Nice, all of that. Nice for a PowerPoint presentation. But in the end, you have important information on the characteristic of a plaque only by imaging.
Yeah. Yeah, Bernardo, I completely agree with you. And I would like to conclude this part. You anticipate me because the imaging, the OCT, yes, but in general, bifurcation guide PCI. We reduce the MACE, the stent thrombosis, when we use the OCT or the imaging, the complex lesion in general, and with the Occupy trial, the Lancet 2024, we reduce the MACE in the complex lesion in general. So I a believer of the physiology, but today we need to integrate it because the data that provided by the OCT are very important and impact on the prognosis, I think. So I manage this case putting a long stenting here. By the way, I can go more fast here. I pass the side branch, the pot,
oh my God.
Real bifurcation. This is the final result here. And after that, I check with the imaging, the result after putting a stent, the diagonal, look here, the bifurcations, very good. Normal apposition, no geographical miss, so good result by the imaging. And after that, I recheck the physiology to demonstrate if my work is a good work or not. So with the adenosine fusion, I will recheck the full physiology and find the presence of complete normalization of FFR, PDPA, CFR, and also the IMR dysfunction is good after the stent implantation. So I conclude this case because the case is not finished here, but because Friday we have scheduled the CTO PCI of this patient tomorrow. So tomorrow I would like to record my live case, Bernardo, for your Congress DEBS in Rome in the last part of this month. I would like to present the last part. I would like to treat with DCB my CTO.
Yeah, you have to use at least one DCB for the DEBS.
Just for the diagonal.
It's not a stent Congress. No?
Yeah. And for the summary of the today presentation, the physiological assessment of a vessel remote from a CTO require careful consideration, as you suggest, Bernardo. The FFR, the IFR overestimate, we discussed before your connection, Bernardo, the real value of FFR and IFR value, okay, because overestimate the severity of a donor vessel lesion in the setting of CTO, okay, but there is a significant heterogeneity in this situation, depending on the caliber of collateral, the rapidity of regression, progression, involvement, different collateral, the chronicity of this process, and also the viability of myocardium after the CTO PCI, the CTO vessel. After successful or CTO PCI, blood flow in the CTO vessel and the microvascular function do not normalize immediately. It increase, but not normalize, but improve significantly over time. This reflects by a decrease of microvascular resistance and regression of collateral. As a corollary, the FFR of the measured donor vessel may increase, reflecting the decrease of collateral stills. So CTO PCI, the whole trial suggest in 2 decades suggest that CTO PCI may be preferred initially to avoid unnecessary, we discussed in the last part of this presentation about this topic, to avoid unnecessary donor vessel PCI or surgical revascularization. And for me, we are believer of physiology, but we come from imaging operator, so the integration between imaging and physiology is more important.
Great, thanks a lot. That was very outstanding. Look at how many people came here to listen to you guys. It's a very outstanding presentation, and the way I like to do a PCI, which is to investigate and always collect new information. Don't just follow flow charts, but use your mind to integrate all of the information that you have. That's the best way to obtain a maximum for our patients. This is something that I'm trying to tell to our colleagues here, not to just follow a flow chart. I had a discussion yesterday with the CEO of Philips here, and can you develop a flow chart on DCB here? He said, I don't work with flow charts. So in the end, I agreed that I will provide a flow chart for just the beginners, but then if you want to do a high quality PCI, you have to use your mind and all of the tools that we have now. So really great presentation, Fabrice. So happy that you joined us today.
Oh, thank you, Bernardo, for this opportunity, because I study for 2 weeks this topic all night. I pass all night to study or trial in the last 20 years, because we here there is Momo, is a really expert of physiology. We discuss every day about physiology. We discuss with the flow chart. I completely agree with you, Bernardo. It's important to use our mind to perform a good PCI and to integrate. We have a lot of a disposal, a lot of system, physiology, imaging, IVUS or CT or integration of that is important to use. Finally, we need to reach a good PCI for the patient.
Thanks a lot.
Thank you very much, Dr. Ugo, for taking the time.
Thank you,
to
Sarah,
join us
for
here
coordinating this. I hope that you will come with us soon, Fabrice. Also just to, as an attending, just to speak and comment with your expertise.
Okay, Bernardo, see you in Rome.
Yes, we will also be there.
Yeah, a lot of fellows will be there.
Yeah.
Okay, thanks a lot.
Thank you very much.
Bye-bye, guys.
Thanks, everyone. Bye-bye.
Fabrizio,
Bye-bye.
presto.
Thank you very much.
Thank you.
Thank you, guys. Bye-bye.